皆様、本日はご参加いただき、誠にありがとうございます。医療は誰が守るべきなのでしょうか。2016年5月、国連安保理決議は2286を全会一致で採択し、紛争下における医療施設や医療従事者、患者への攻撃を強く非難しました。そして今、私たちはその10年という節目に立っています。しかし、このセッションはその節目を記念する場ではありません。現実がどうであったのか、そして何が変わり、変わらなかったのか、それらを検証する場です。問うべきなのは、決議に何が書かれているのではなく、現場で何が起きているのか、現実がどう変化したのか、そして我々はどのようなアクションを取るべきなのかだと考えています。本日のセッションでは、この問題を多角的に捉えるために、以下の8つの観点から議論を深めていきたいと考えています。第一に、決議2286はなぜ今なお重要なのか。第二に、医療への攻撃は現在どのような状況にあり、どのような変化が見られるのか。第三に、この問題は国際人道法および医療の観点からなぜ重要なのか。第四に、これまでどのような取り組みが行われてきたのか。第五に、どのような課題に直面しているのか。第六に、なぜこの問題は未だに続いているのか。第七に、私たちは国家とどのように向き合うべきなのか。そして最後に、政策決定者やメディアを含め、どのような行動を求めていくべきなのか。本日の参加者の皆様の中には、この問題について初めて聞く方もいらっしゃるかもしれません。そのため、このセッションでは、できるだけ分かりやすく、しかし同時に本質的な議論となるよう心がけて進めていきたいと思います。それでは、パネルの皆様と共に議論を進めていきたいと思いますので、それぞれ簡単にご紹介させていただきます。まずは、国境なき医師団から、ドクター・マリア・ゲバラです。医師であるマリア・ゲバラは、スイス・ジュネーブを拠点に MSF のインターナショナル・メディカル・シークレッタリーを務めています。2024年から、2004年からですね、もう20年以上にわたって人道援助活動に従事していまして、2021年2月に、現在のインターナショナル・メディカル・シークレッタリーのポジションに就任する以前は、MSF スイスのグローバルヘルスアドバイザーを務め、医療への攻撃を担当していました。マリア・グエバラ、本日はよろしくお願いします。そして、2人目は、クリスティーナ・ウィレ、代表です。クリスティーナ・ウィレは、武力紛争下における民間インフラへの暴力、とりわけ医療に対する攻撃に関するエビデンスを強化する組織、インセキュリティ・インサイトの創設ディレクターです。人道支援、医療への攻撃を追跡する AI 主導の先駆的な取り組みを主導していて、そのデータは人道報告書や国際メディアに広く引用されています。よろしくお願いします。そして、3人目は、ドクター・スリム・スラマです。ドクター・スリム・スラマは、世界保健革新サミット、WISH の代表責任者です。これまで10年以上にわたって、世界保健機関 WHO に勤務し、NCD、ノンコミュニカブル・ディジーズなどの予防および管理に関する取り組みを主導するとともに、子宮頸がん、乳がん、小児がんといった世界的プログラムの責任者を務めました。現在はカタール財団における世界保健革新サミット WISH の代表責任者として、保健分野におけるイノベーション、政策、パートナーシップに関する国際的な取り組みを主導しています。ドクター・スラマ、よろしくお願いいたします。そして最後に、プロフェッサーの越智恵先生です。 越智め先生は立命館大学大学院国際関係研究科の准教授です。最近では変革的正義と題する学際的なプロジェクトを運営しており、立命館大学の国際平和ミュージアムと協力して、戦争犯罪アーカイブ化に関するサブプロジェクトを組織しています。国際刑事手続法の研究で、2025年に文部科学省の科学技術分野の文部科学大臣表彰、若手科学者賞を受賞しております。越智先生、よろしくお願いいたします。それではここからは、私は、英語で、ファシリテーションをさせていただきます。Before we start, just a quick reminder, we have a very tight schedule today with about 5 minutes for each speaker in the first round. So I would like really encourage everyone, speakers, to focus on your key messages. The idea of this first round is not to be exhaustive, but to highlight your key perspectives. We will use the second round to come back to other important points and deepen the discussion together. So just to make sure we have enough time for discussion, I may gently interrupt if needed. So less is more for the first round. Then Maria Guevara, the first floor is yours. About 5 minutes, please.
Yes, thank you. Thank you, Sanjiro, and thank you, everyone. Konnichiwa, konbanwa. It is a very tall task to go 5 minutes on this topic that I'm quite passionate about, that MSF has been fighting for many years, especially in this last decade, and saying no to the unacceptable. Next slide, please. I just wanted to remind that on May 12 this year, I was actually in the UN Palais to deliver a statement and to help moderate a discussion on a high-level panel that was convened by Spain, Egypt, Uruguay, Japan, and New Zealand, who are generally the friends of 2286 10 years previously when it came through. But I wanted to remind on why 2016 on May 3rd and that unanimous landmark decision was important for MSF because of a series of attacks leading up to that date, especially on October 3rd, 2015. As a reminder, this was one of the darkest days in MSF's history. I remember when we received the call that day, I was actually in Japan with the executive committee discussing what we needed to do around making sure that the MSF activities were recognized around the world. We received the information that at 2 a.m., our MSF Kunduz Trauma Center was being bombed. Precisely repeated strikes from a U.S. airplane that was destroying the hospital, and it killed 42 people, including 14 MSF staff, with patients burned in their beds, as you can see in this picture. Next slide, please. You know, MSF was performing its duty under the Geneva Conventions by treating any and all patients in that area. It was a facility, one of its kind, running for 5 years prior in northeastern region of Afghanistan, providing trauma care, servicing over 1 million people. As you can see, after the attacks, it was a precise attack to the facility itself. And the GPS coordinates were given. And that attack lasted for an hour, despite numerous calls to the US government to remind them of our coordinates. The next slide, please. But what we received when we called for an independent investigation, which went unanswered, was that this was a tragic incident from the US Central Command stating that it was a combination of human errors combined by process and equipment failures, all factors that contributed to the fog of war. We felt this was an unacceptable excuse for an unacceptable act. Next slide. Because of this, we went to the UN Security Council with our then President Joanne Liu, along with ICRC, to remind that medicine should not be a deadly occupation and patients must not be attacked or slaughtered in their beds. 10 years later, as I mentioned, we went to the high-level panel, and we also published a joint call with ICRC and WHO to stop the attacks and uphold the resolution 2286 this year. So how do we move from that? Despite the conflicts that are keep coming and 10 years of broken promises. Next slide. There are many, many cases throughout the years that MSF has been witness to. And these are just some of the pictures, and we have just discussed at length Gaza and Palestine, so I will not go into that. But I just wanted to flag, just not but a few years after, in Afghanistan itself. And Dasha Barchi, which is the picture right in the center, where in May 2020, armed men went into the facility and started killing women and children in their beds. The mothers who were ready to provide to deliver were killed in their beds. And these are other plethora of cases, whether it's from Ukraine, Sudan, South Sudan, Haiti, where our ambulance was attacked midway and our patients were killed in mid-transit. The scale of intensity is unconscionable and should not continue, because at the end of the day, it is about lives and provision of care to those people who are in most need. And you spoke at length about Gaza, but one of the things, the two things that are most disturbing about Gaza is essentially the asymmetrical challenges that we've been facing and the complete barricading of human aid coming in, but also the mere allegation that says we have lost protection under IHL, which should be met with clear, strict conditions, and those have not been met. Next slide. In many years of looking at attacks on healthcare, we underwent an evaluation in medical care under fire in 2010 and 2011 already. And here is just a sampling of what those typology of attacks mean. We know what the different intentions are and what the triggers are, and we understand what what it could be economic, from indiscriminate to directed attacks. And we are studying this at length to understand how we can be better prepared in the field. Next slide. But just to highlight the intensity of what's happening, we have grown significantly in the last decade, and more of those are in conflict settings and with addressing all the vulnerabilities. The numbers of patients that we are seeing, 16 million outpatients, 2 million emergency room, over hundreds of thousands of surgery, women and children are all our patients. And these are important to highlight because, again, want to remind that whether it's South Sudan or Sudan, we are providing at least 82% of all global, we are witness to global deaths from attacks on healthcare. And unfortunately, what does that mean is if you destroy the health facilities, and MSF, for example, in Sudan, providing 850,000 outpatient consultations in just 1 year in 2025, 29,000 births. In Gaza, we provided 913,000 outpatient consultations. In Ukraine, it means 10,000 patients having to be referred on ambulances, 60% of them with war-related injuries. Again, this means a lot of people's lives are at stake that is implicated with just an attack. Next slide. So there are many, and this is again highlighting the increasing numbers that we are seeing of conflict situations and the immense investments we're putting on these different contexts. Next slide. But why are we seeing this? There are many tensions that are evident in what we see. Mainly, a lot of that is in the counterterrorism narratives that tends to blur the lines distinction between law enforcement and law of war activities. And it really implicates the neutrality of healthcare in armed conflicts and therefore the protection of healthcare personnel, facilities, and the wounded. We also see the conflation of health security and security at all costs is a double-edged sword, meaning that in public health emergencies of international concern, which we're facing right now in DRC with Ebola, in the middle of a conflict situation, when you address the rights to health versus rights to peace, you need to find the balance. The emergence of the communication of battlefield, the asymmetric warfare, and also the centrality of medical ethics. Finally, in my last slide, here is the next slide, is the major call.
Okay, Dr. Maria, I'm going to stop you there just in the interest of time, but we'll come back to your last important points, calling for an end to impunity in the discussion. Thank you very much, Maria.
Thank you.
Then the next is Director Christina Wille. The floor is yours.
Thank you very much. I am also under the challenge of putting everything I need to say within a few minutes. So what I'm going to share with you is an overview of the monitoring we've done over the last 10 years, and to show that the issue has not only got better, it has not been able to maintain. It has spiraled and got out of control. And this is the shocking number of total events, over 18,000 attacks on healthcare in just 10 years. And I want to share just sort of 3 key points with you here of why I think this is just they also illustrate such important points. It is not essentially military medical services affected, although they are equally protected. It is the civilian health services. And this is really very well illustrated by the extent to which maternal healthcare has come under attack, denying communities of their most hopeful moment in healthcare. This highlights how this is an IHL issue, but equally one of civilian protection. The second point is one that I think you've already seen in some of the films. It is also the supply and the access that is increasingly being restricted. And that has important implications because it means that healthcare, even when people are there, cannot be provided as needed. And the third data point I want you to think about is who are the health workers who pay with their lives. Some of them work for international organizations like MSF, shown in yellow here. Others work as internationals. Others work as the local staff for international organizations, shown in turquoise. But in red are all those local health workers who work under ministries of health and other local structures. And they are really bearing the brunt of this violence. And the question is, how and why is this happening, and what do we need to do? The other key point here is it is states. Yes, non-state actors have doubled the attacks during those 10 years, but the really big spike, that has been states driving this. The other issue is that sometimes I speak to people who think it is essentially either Gaza or Ukraine. It is not. It is happening in so many other contexts, and it is spreading to more and more context. And this is also illustrated when we look at where maternal health has been affected, already in Syria, all the time through the main conflict, in Myanmar and other locations. And then a final point from the data is that when we look just at the states and the attacks they carry out, some do it across borders in other countries, others do it domestically. And there are very distinct patterns of how this violence against healthcare is carried out. And that has important ways to think about of what can and cannot effectively be done in responding. And then finally, I just want to let you know that we also have a map where you can look up these things. But with this, I'll stop here and look forward to the conversation around these issues. Thank you.
Thank you very much. Thank you very much. Thank you very much, Director Christina. Then may I invite Dr. Suram to share your key points around 5 minutes?
Thank you very much, colleagues and MSF Japan for the invitation. I was a year ago in Osaka at the Expo, and we had a similar conversation with MSF Japan, ICRC, and our colleague from UNRWA and SETA that was before in the previous session. So very happy to see that that conversation continue. It's an important one. And Maya mentioned Kunduz was on the MSF board 10 years ago, and we had that discussion. We thought that things would evolve, that we'll have more accountability. But as the previous colleague mentioned, the situation is worsening, so it's more than a concern. It should be an outcry, and we haven't really seen this happening yet. So next slide. You have seen it, it's everywhere. It's covered in the media almost on a weekly basis, covering all settings. We tend to see sometimes in the media a focus on few countries, but as Christina just mentioned, it's increasing. We have different system of monitoring. I mean, Insecurity Insight and the colleagues from the Safeguarding Health in Armed Conflict have those reports, those maps. We have also the surveillance system for attack on healthcare that WHO have established since 2017. I was last week in Geneva with the colleagues, and they are about now to generate a quarterly report. Just to give you, I mean, a number in perspective, since the beginning of this year only, 568 incidents, resulting in more than 416 deaths in 14 countries. And the overall system is only counting at a maximum 25 countries. So a lot of countries are not reporting. Documentation is still not fully there, which is one of the challenges. And as we heard from one of the participants on a workshop we recently organized, documenting is in itself a form of resistance, a way not to forget, as you have seen it in the video that you were showing. I think there is a need also to document, not to forget what happened, whether at a level of one single attack or even at war crimes and genocide. There is an importance of documenting and also using that information, which is one of the point I would like to raise. Next slide. So for me, the focus is why despite all that evidence, despite all those suffering, despite mobilization from different stakeholders, there was limited political priority or traction. The strong norms, we heard about the international humanitarian law, the right to health, various elements that in terms of procedures, even in the military system, strong norm but weak enforcement is one element. The fragmentation of factors and leadership perhaps is one point that we need to think about if we want to be a more cohesive as a policy community, is to analyze better who is doing what in this front and how can we support each other and create more synergies. Because we have also some competing framing in the narrative. Some look at it from a humanitarian law, and I think it's an important element, but the right to health do not substitute to humanitarian law. So how we maintain from a right approach or from a medical ethics accountability approach, those framing together, how we are more cohesive. The data system, as I mentioned, are important, increasing. There's a lot of information out there, but there are also a need to better use within different mandate. Some, like our colleagues from WHO, collect data, but data not necessarily used for accountability, also for continuity of care. So we need to understand how we can mobilize the various actors that are part of this agenda. And of course, the situation we are in, the geopolitical context, is a very difficult one, with manipulation, reinterpretation of norms, including on the Geneva Convention and the protection of hospital. You have probably heard recently ICRC very vocal of that with the global initiative on upholding IHL. A hospital or school is under the Geneva Convention and IHL protected, but there is a tendency also to use IHL to remove that protection with sometimes necessarily an argument and documentation that these settings can be used for military purpose. And this is something that is worrisome. Next slide. So as I mentioned, there's a lot of factors, and I think it's important that that ecosystem is analyzed. Academia, UN agencies, special procedures to the UN agencies, a lot of NGOs extremely active, showing also innovation in the documentation, a research consortium that Insecurity is part of, I mean, the RIA that is mentioned on this slide, the researching the impact, 7 years of documentation of qualitative research, inclusive research with communities and colleagues affected. But we see that there is still, I mean, limited traction. Next slide.
Dr. Slammer,
Yes.
thank you very much for your presentation. I'm going to stop you there, just in the interest of time, but we will come back to these points in terms of activities, advocacies, and other actions. What has WISH have been doing? We'll come back to this point in the second round. Thank you very much. Then, since 80% of Congress participants are Japanese language speakers, and the presentation contains many legal terms for the presentation of Professor Ochi, we'll ask her to deliver her remarks in Japanese. Ochi 先生、よろしいでしょうか。
はい。
Ochi 先生、8分ほど大丈夫です。
はい、承知いたしました。それでは始めたいと思います。皆さん、こんばんは。本日は貴重な機会にお招きいただきありがとうございます。私も一応ドクターではあるんですけれども、他のパネリストの皆さんのように、の前でドクターというのはちょっと恥ずかしく、あえてプロフェッサーとさせていただいておりますが、I have PhD in law です。なので、今日のお話は非常にリーガルなものになると思われます。私のテーマは医療に対する攻撃は処罰できるかというもので、ドクター・ゲバラが最後のスライドでお話ししようとされたことと被っているかなとちょっと思ったんですけれども、一緒にお話しできればと思います。近年、今回のテーマであります決議から10年経ちましたけれども、これまでのパネリストの方のご報告に分かるように、医療への攻撃のレポートの数というのは増えているということですが、同時にですね、国際刑事裁判所、インターナショナル・クリミナル・コート、ICC による刑事訴追への期待というのは高まっているかなと思いますので、今日は私のお話をここに焦点を当てていきたいと思っています。法的枠組みについてはもうすでにご案内かと思いますけれども、戦争の放棄慣例、それからジュネーブ諸条約、インターナショナル・ヒューマニタリアン・ローと呼ばれるものが、ございますが、そのうちの一番右ですね、重大な違反、それから著しい違反というものについては、戦争犯罪と呼ばれて区別されております。これらの部分が、いわば処罰可能な違反の部分ということになってまいります。で、この戦争犯罪としての医療に対する攻撃というのは、多岐にわたるものですけれども、今回はその中でもコアなものに絞ってご紹介しています。非常に文字が多く、恐縮なんですけれども、見ていただきたいのは3つの点です。まず、医療というのは文民、そして民用物ということに分けられますので、これを狙った攻撃というのは戦争犯罪に該当いたします。それから病院に対する攻撃というのも、これ別の形の犯罪として、規定されているものです。そして、また医療、特に赤十字国際委員会に対する故意の攻撃というのも、まだ別のタイプの戦争犯罪として定義があるということになります。これ以外にも、医療機器の略奪などですね、これと特にウクライナ戦争で問題になりましたが、これは戦争中の略奪という別の犯罪に該当しますし、また殺人等はですね、また別の犯罪ということで非常に複雑になってくるんですが、ここでは3点紹介したいと思います。で、実際に ICC で、病院に対する攻撃が、訴追されて有罪になった事例がございますので、ご紹介、したいと思います。これはコンゴ、DRC、デモクラティック・リパブリック・オブ・コンゴにおける、内戦でのですね、反政府武装勢力、武装組織による、村々への攻撃の途中にですね、ヘルスセンターに対して、砲撃を行ったものについて、有罪判決が出たものになっております。で、ここで紹介したいのはどういった証拠があれば、この犯罪について訴追が可能なのかということです。で、スライドの左の下の方に証拠ということで3つありますが、3点について立証する必要があります。 まず攻撃当時、中に患者が収容されていたという証拠がありましたので、これが病院であったことが証明できました。それから次に軍事利用されていた証拠がない、ということが重視されます。これが軍事利用されていなかった証拠ということで少しややこしいんですけども、証拠がないことによって立証されるということになります。そして最後に、攻撃者側の組織の中で、この、ヘルスセンターのことを、診療所と呼んでいたという、これ内部の証言ですね、があったので、これが病院であることを攻撃者が認識していたことが証明されました。このように3点についての証拠が集まらなければ、これが病院であると一般に知られていたとしても裁判で通用する証拠にならないというところがポイントになってきます。で、近年の不訴追事例ということで、ウクライナとガザに今回絞っていますけれども、ロシアとガザそれぞれについて ICC は逮捕状を出しております。ロシアに関してはプーチン大統領及びリボワベロバ大使に対して、子供の移送について、でそれから軍司令官4名について、民用物攻撃、これは発電所に対する攻撃についての、逮捕状が出ておりますが、多くの病院に対する砲撃や、略奪等に関しては、総員に入っていないということになります。また、ガザについても、ネタニヤフ首相、そしてガラント国務長官の2人にですね、今のところ逮捕状出ていることが公表されてますけども、これも飢餓の戦争への利用と文民殺害ということで、病院に対する大規模な攻撃というのは、訴追対象になっていないということですね。医療攻撃に含まれないということになります。で、なぜなのかと、何が難しいのかということをご紹介しますと、実務的な課題がいくつもあると言えると思います。一つはまず証明の困難です。故意について立証することがまず一つ難しい。これは病院だと認識していて、病院だと思った上で攻撃したということを立証しなければならない。これは軍の中の人の証言がないとなかなか難しいと思います。それから軍事利用の証明です。これは証拠がないことを立証するという悪魔の証明になりますから、これについては弁護側が出してきた証拠を潰していくということをしなければならない。それから情報の非対称性というものがあります。捜査の困難についてももちろんこれは皆様ご承知の通り、そして倫理的問題がありまして、特に医療関係者、中立性の維持というのが大事な部分もあるでしょうし、それから被害者のプライバシーを保護するなど多様な制約があると思います。ただですね、アカウンタビリティの追求のための医療の役割というのは非常に大きいです。ここでぜひ議論したいところでもあるんですが、まず証拠の収集、これは医療従事者の証言というのは非常に重要です。それからオシンと、それからサテライト、衛星を使った証拠やデジタル証拠というのも最近は非常に重要な役割を示していると。それからあと2つは、ちょっとこれもなかなか新しいことではあるんですけれども、専門家、としての証言ですね、科学的根拠に基づく証拠分析ということで、ができるということ、それから法廷の友、アミクスクリアというのがありますが、これは専門家として裁判所に意見を提出するということがあります。ICC についてもこの制度がありますので、今多いのはプロフェッサーが出しているものが多いんですけれども、NGO とシビルソサイティの人たちが出してくることもありますので、こういった形で ICC だけではなく、IC 国際司法裁判所国家間の責任を追及する場面であったり、または国内の裁判所であったり、こういった証拠の提出というのが重要な役割を果たす可能性が高いです。以上のことをもちまして、結論としては、非常に短い報告ではありますけれども、医療攻撃というのが戦争犯罪になり得るということ、しかし訴追が非常に困難であるということ、そこで証拠と制度強化が必要であるということを強調して終わりたいと思います。ご清聴ありがとうございました。
はい、越智先生、ありがとうございました。From now, we will shift to the second round of discussion. I will ask some questions to each speaker to catch up the latest trend, but also to understand the issue furthermore. I'd like to start from first Christina. You shared several data and the trend. Let me start by grounding us in the current reality. So Christina, based on your data tracking over the past decade, what are the key trends we should understand today?
Thank you for this important question. So I think the importance of insights from the data depends what you want to do with it. I think one issue is that for each context, it is important to look at the specific environment to understand what actors use violence, why do they do it, and what can be done to mitigate the risk of this happening, but also, very importantly, the consequences of such violence and how to maintain health services. But if we are looking at it from the perspective of driving forward the legal accountability around this, we need to look at the events that are conducted by a particular actor for which there is enough evidence to really provide all the details to help build a case. So yeah, in short, the answer is it depends on your objective of what you want to look at with the data. And I'm very happy to share data if people want to look at specific aspects, whether around countries or topics.
Thank you, Christina. Then I have a question to Maria. Previously, like more than 10 years ago, when we have the attacks on health facilities, especially health facilities, especially by states, they tended to say, oh, that was a collateral damage, or that was a serious mistake, and etc. But these days, some states are insisting that the health facilities are losing the protection, even under the IHL, especially in the front line. Do you see the change of the explanation by states these days?
No, it's a very good question, because there's what we were seeing is this misuse of the legal frames and this kind of impunity allow mere allegation to be said like this because of the contrary information that we're saying. And I think this is one of what MSF is trying to do is actually show facts and evidence and witness to what is happening on the ground, to inform, to build the data and the evidence that Christina was saying already, and what also Professor Ochi was saying, as well as Slim, is that this is important to highlight. Unfortunately, that onus is resting on the people who are being attacked. That proof of burden shouldn't have to sit with those who are actually under attack. But that's what the laws are there to protect. And I think, one of the things we're trying to push for MSF is how do we empower our teams to be able to also mitigate that and engage with actors on the ground and to highlight why the medical action should be preserved in its medical impartiality and neutrality. And I think this is where I was trying to highlight is that ethical perspective on that. And what I'm afraid right now is there's this misnarration that Slim was saying, is that manipulation of narratives today is very much entrenched in how we frame everything around security or counterterrorism, or which disables the capacity of health workers to counter that narrative better. And I think we have a power to do that with MSF, to really bear witness to what we're seeing and highlight that there are dual legal obligations that medical personnel are having to face: the duty to care and duty to provide care, as well as to ensure the safety of the community. And that gets instrumentalized today in conflict situation. We need to continue to bear witness to that fact.
Okay, great. Thank you very much, Maria. Then I have having heard that from MSF. I have a question to Professor Ochi. Where do accountability efforts? So we are making a lot of accountability efforts, but where do accountability efforts most often break down? Is it in intent or access to evidence, or political constraints?
Thank you for the question, and I have to declare that I'm not insider of any public prosecution office or any court, so I cannot say for sure. But based on the research that has been already taken place, the empirical researches, I see there are lots of different types of obstacles. Obviously, some of political, some are physical. Previous cases, most of them are conducted after decades of years passed since the occurrence of the crime. So obviously the evidence corruption collapsed, and then destruction of the evidence, and also the memory fatigue. Most of the witnesses survived the time, and they do not have clear memory of what happened when, what time, of course. So that's the evidence challenge is very big. But what we see now is, the investigation is going on under the ongoing war. And that has different types of obstacle. That's of course it's about the access to the information investigation. Even we now have satellite images, internet, local people with iPhones or some more simple mobile phones with their hands and shooting the photos and video that they saw. So all the people at the crime scene can now save the data and transmit it to the international internet world. So we have a lot of advantages now compared to 10 years ago. But yeah, to name a few, it's a lot and a lot of things. And yeah, all challenges has to be overcome so that we reach accountability.
Okay, thank you very much for sharing your points, Professor Ochi. And then we come back to now Dr. Slammer. Dr. Slammer, over the past years, we have seen multiple initiatives to try to reduce such attacks on medical care. Now, from your perspective, as a director of WISH, what has been done and what seems to be working?
Thank you very much. As I alluded to, like anything in policy, the importance is being able to build a coalition of the willing, a coalition that understands what is at stake, what are the strategic levers, and the ability to act globally. I mean, you look at with the HIV movement or whatever, I mean, claiming health, there are, I mean, ways to mobilize people. So at which we just took a starting point 2 years ago in 2024 with WHO. We had a partnership, and we wrote that report in the line of fire, and can be shared in the chat, where we were documenting specifically based on the system that WHO has put. There's the number of attacks, the consequences, the impact. We often use the reverberating impact. It's not just the direct impact, but what lasts, with all the work that also the stakeholders have done over the years, RIA, Insecurity Insight, all those networks. And from that, we say, okay, what can we do? It's good to document. And I mentioned, I think documentation is somehow a first form of resistance, of memory. I think your country and Japan went through this difficult time. I think the culture of memory for human security, I think, is an important element in itself. So we started from there saying, we should not forget, as you mentioned, that very moving writing in your videos. I think we don't want to forget what happened across Syria, Yemen, Sudan, Gaza, everywhere, Ukraine, without also being partial. Because the problem we are facing is that we have also a very partial reading at the moment. So we wanted to go back to the core. IHL is one aspect, and we need actually to revive those rule of war. But as our humanity is at concern, I think it's about human rights at the first place, and the ability actually to treat this for whoever has to be in the position of being vulnerable. You know, I never thought in my life that I will be under the bomb. I live here in Doha, and we've been bombarded in a country that have the ability to defend itself. But when it comes to you, it can be anywhere. And I think essential element of preservation of the protection of civilian, which is the umbrella. I mean, we are talking about that resolution, but schools, any element of livelihood, agriculture, element that allow also to get treated as hospitals, all those essential services should be preserved. So we took this approach of being very systematic, of understanding who are the stakeholders. And as Professor Ochi mentioned, at the end of the day, it's about member state. So if you want to exert pressure on member state, who are the member state that we can work with? And I think in the previous session, you referred to many member states. There are some member states that have even acted in their humanitarian response, in their health response, in their foreign policy, the protection of medical mission. So we work with them. I mean, Spain was one, but we have, Ireland, we have Australia recently with a declaration on protection. You have multiple countries across the globe that are taking stand progressively. And we wanted to say, can we rebuild? The Resolution 2286, since its inception, have more than 30 countries that were signatory. Japan was at the forefront. It's not by chance that we came to Japan a year ago, because the concept of human security was at the forefront of JICA and Madame Sagato. Vision about human security in Japan was very important. And we use this. You use actually the platform that exists. The UN Security Platform is one of them. We have the Human Rights Council with whom we work to strengthen also the rule of law. We have the World Health Assembly and multiple other NGOs that have, like yours, those platforms. So my point is, let's be strategic. Building those coalitions sometimes do not happen in light, it happen on the back end, and we need actually to be able to focus. So our approach has been strategic to map stakeholders, understand who can do what. There are some connex topics that are important, like the main determinant of death by state actors in conflict are bombs in highly populated areas. The use of explosive weapons in highly dense populated areas is one of the main issues. So there are countries like Ireland a couple of years ago that have also pushed for that. The arms treaty, the ability to stop countries sending arms to belligerent where there was clearly, documentation of war crimes or even genocide. These are also elements. So we work with all those stakeholders, NGOs, UN agencies. The second point was on data. The ability to better strengthen, as I mentioned, some countries are documenting, but a lot of other countries in conflict are not documenting and reporting back. There are the various groups, the definition even itself on what constitutes an attack is not necessarily uniform. So we were also trying to work on that front, understanding who is collecting what. How can we use data across mandates? As I mentioned, some of the organizations do not necessarily collect data for accountability, but it can be used by others. And collecting this data is important to reinforce. There is very few funding, very few support for those data systems, whether NGOs or even UN agencies like WHO. Pushing countries to invest in supporting data strengthening and collection is in itself an element. And the last point is really to have the community that help us in accountability, like Professor Ochi and others. But accountability is not just about holding perpetrator into account. As a Lancet Commission just been released last week on conflict and health, one of the elements was the accountability for the people that we are supposed to serve is to be able to preserve, maintain the continuity of services. So being able also to measure our accountability, not only by holding perpetrator into account, but the ability to maintain and restore those services with the support of those who are at the front line. And I will stop with that. So this is what we are about, maintaining that pressure and being able so to have a more cohesive community across borders. Thank you.
Great. Thank you very much, Dr. Slammer. It's good now that we are shifting not only about describing a problem, but how to stop, how to reduce the attacks on medical care, how to stop normalization, how to restore protection of healthcare. But the reality is, all of us, we know that despite awareness, commitments, and efforts, attacks continue. The situation is getting worse. And today's many panelists are saying that states are central actors here. And so I have a question to some of you, like Maria and Slammer. Maria, okay, when we say states are central actors, what does meaningful engagement with the states look like in practice?
So I think from MSF perspective, I mean, our main entry points in any of the projects that we run are always with the state, especially with the Ministry of Health. So we do negotiate access into the country with states, so that it starts there and helping the states understand who we are as an actor and our very clear hat of being a medical organization working in humanitarian settings. And I think this duality of roles is important. And that voice that we have as a medical actor empowers us not only to speak on and remind what is under the IHL as protection of medical actors in conflict settings, but also to remind of the ethical duties that are behind providing medical care. And that neutrality and impartiality should always remain, whether it's a stable or unstable context. And I think this is that's what it should mean about MSF engaging and other medical actors engaging with member states. Because of our clear function working mostly in conflict situation, and it's part of our mandate is to bear witness to that and that documentation and counter the narratives that are more and more the case today and highlighting what is true reality. And in a world of technology with AI and the manipulation of that information, you don't really know anymore what is true and what is not. And I think our witnessing is very clear on this to really bear light on what is truly happening on the ground. And that's how we engage with all those who are supporting the cause of protecting IHL. But it's not only the obligation of those states who have signed, but it's also the obligation of states to comply and ensure they are complied and helping them understand what the stakes are on the ground. And I think this is an important role that MSF can truly play on this. And be, that this is a collective work of every single one of us. But it is the accountability measures that states should be providing to the law.
Okay, thank you, Maria. Then from data collection, data perspective, I have a question to Christina. From data perspective, what are the main gaps or limitations that constrain effective advocacy? Do we have any, according to your points of view?
Thank you. That's a really important question. So I think the first thing we need to look at is how good is our data in terms of actually covering the full scale of the problem. And there are always issues with where there is no access, physical access. It becomes very hard for structured data sharing mechanisms to work. And then we have to use open source mechanisms to identify this. But then it becomes a different story depending on what sort of systems we are using, of who is affected, where the biggest problem are. So I think that's one thing that when we look at details, we should perhaps not be too focused on just a number, because a number can be the representation of unequal access to sharing what has happened to you. So I think the advocacy really has to focus on telling the story of how the world is unable to protect healthcare at the moment, and what can be done to protect it, and how much it is an issue of protection of civilian and access to healthcare, and the difficulties for people who want to care for others to be safe. So I think we need to focus on the messages around it. The last point on the data is, I think where the data is extremely helpful is to ground us in evidence that these are not subjective perceptions of a big problem, but that there is real evidence of how it's happening. But the advocacy has to be on the subject matter rather than a number.
Great. Okay, thank you. Thank you very much, Director Christina. Professor Ochi, from your point of view, what would materially strengthen accountability? Is it evidence systems or domestic trials or international mechanisms? From your point of view, what would materially strengthen accountability?
Yeah, that's an intriguing question. I think, first of all, it's good to be reminded that states dominate the authority to punish individual in modern era. We are not in the medieval time that people punish each other, based on their own ethics standard, but we live in this enlightened world. So states dominate the power to punish. So states with the biggest, I guess, the actor that we have to really think about. And also the ICC or those international organizations are made by states. So that's another reason why states are the key, which is, I think I'm adding something on what Dr. Guevara already said. So when you talk about material, not sure whether we need any sort of investment on certain fields of policy making at the international or local level. But also, I think what we see now is this international network of like-minded people who is collecting and who is litigating before the many different types of national, like domestic courts. For example, in Argentina and Spain, there are courts that open their own domestic courts for the crimes happened in outside of their own country based on the jurisdiction called universal jurisdiction. So yeah, we of course have to persuade states to open to use their authority to punish individual, to implement and deter future crimes, and to let people to stop thinking about to having this option to attack those protected by international humanitarian law. And also, of course, states here means not only the third states, but also the states which are actually fighting each other. And we have to let them understand that it is also for them to reduce the number and, of course, seriousness and brutality of casualty during the war. Based on the history, Japan has learned a lot of lessons based on the history, like how much it costs by violating international humanitarian during the war. So learning history, adding a lot of instruments and a lot of things to do. But obviously we are moving towards a better future, I guess. Thank you.
Thank you. Thank you very much, Professor Ochi. And then Dr. Sramar, you mentioned that several initiatives you have been taking as a wish in terms of making alliance with several different actors. But is there any space that we can better align states, international organizations, and data actors into a more coherent system?
I mean, there are various.
I want to get something from you that, according to you, what concrete shifts are needed from states to reverse this trend?
Well, in terms of states as member states or countries, as you heard, it's we are in a situation of what I call bullying diplomacy at the moment. I push you and I see how much you can take. You can trade tariffs or you can trade something else. It's very transactional. So the first element is bringing values and principle. The values of life, of humanity, that is the shared humanity, and our ability to resolve big challenges, and we have multiple challenges to resolve so that the next generation look at us in a way that is more dignified than what we see at the moment. I don't want to be part of the history of those who will leave this world in a way that the princess. So there are countries that have, some of the approach, and we are trying to work, as I mentioned, across platforms. Sometimes the policy platform are fragmented. We don't have necessarily our entry point. The UN Security Council somehow is blocked, but you can use the Human Rights Council. You have the World Health Assembly. You have, informal networks. The question is how you bring this into a cohesive policy. It doesn't mean that everyone is aligned. It doesn't mean that everybody is speaking the same languages. But as Christina mentioned earlier, we need to keep the eye on the ball. What do we want to do? At the end of the day, is protection, is access, is the ability to stop it. So I think there are multi-pronged of this approach. Your platform and others, as I mentioned, being able, also those who are hearing us in Japan, you have people in Japan that you can activate, your parliamentarian, your organization, you can somehow put pressure. When I came last year, we went, to the Ministry of Foreign Affairs, we went to JICA, we have, colleagues from like Akiro Seta that is very well, known in Japan community. MSF, you have been at the forefront yourself. So my point is, as Christine also mentioned, sometimes be contextualized. Contextualize the narrative for advocacy and for the purpose. If you are in the country itself, as Maya mentioned, like MSF, we used to go to the Ministry of Health and others ministry to be able to negotiate that space of impartiality to maintain our services and access to the vulnerable population. So it depending whether you're acting at a global, national, or regional level, but I think there is a room to be much more cohesive. Now, whether that space bringing all together exists, no. There have been several calls for a coalition. That coalition is more informal of people that know each other, but I think there is a need perhaps to connect the dots, and this is why those moments are important in various regions, in various languages, to be able to contextualize the advocacy. And each of us as citizens in our respective countries can do something to move this other agenda forward. Thank you.
Okay, thank you very much, Dr. Slammer. And then here, we'd like to introduce our special guest from International Committee of the Red Cross, Shoko Hanzawa-san. She is the head of delegation in Japan of ICRC, and as you can imagine, that she has been also working on this topic very actively since years ago. Hanzawa-san, from here, we pass the baton to you, that you can please share your perspective with us. You have around 5 minutes.
はい、どうもありがとうございます。本日ですね、このセッションに参加して皆さんの議論を伺いながら、私はある一人の女の子のことを思い出していました。2024年1月、ガザで亡くなった6歳の少女、ヒンド・ラジャブちゃんです。そしてもう2人、彼女を助けに向かったパレスチナ赤新月社の救急要員、ユースフ・ゼイノさんとアフメド・アルマドゥーンさんです。ヒンドちゃんは家族と共に避難する途中、車の中で攻撃を受けました。彼女は亡くなった家族に囲まれた車内で何時間も助けを待っていました。電話口で怖い、迎えに来てと訴え続けました。彼女は助けを待つ車の中で殺害されました。そして彼女を救うために出勤した救急車もまた攻撃を受け、私たちの同僚である救急要員たちは命を落としました。私は時々、ヒンドちゃんが最後に見た景色は何だったんだろう、ユースフとアフマドは最後に何を思ったんだろうと考えます。今日皆さんがセッションの中で取り上げてくださった国際人道法は戦争をなくすための法ではありません。むしろ戦争という最も残酷な状況の中で、それでもなお最低限の人間性を守るためのルールです。病院を攻撃してはならない。医療従事者を標的にしてはならない。それは単なる法的義務ではなく、人類が維持しようとしてきた、これ以上下げてはいけない倫理の一線だと思います。しかし今、その線が世界各地で崩れています。医療施設への攻撃、救急搬送の妨害、医療従事者への威嚇や拘束、こうしたことが繰り返されるとき、医療は守られるべきだという原則そのものが空洞化していきます。だからこそ必要なのは、単なる懸念の表明ではなく政治的なコミットメントです。国際人道法を守るという意思、そして紛争当事者に対してその遵守を求め続ける意思です。 法はただそこにあるだけでは機能しません。それを守ろうとする政治的意思が必要不可欠です。ドクター・スラマが言及してくださいましたが、国際人道法の守護者である ICRC は現在、国際人道法グローバルイニシアチブを進めています。その中で私たちが何よりも重視しているのは、武力紛争下の病院に対する実効的な、つまり言葉だけではない、本当に機能する保護の実現です。医療施設を盾にさせないための措置や、攻撃前の事前の警告を形骸化させないための指針など、現場の命を救うための具体的な提案を進めています。そして私は、日本でこのテーマを語ることには特別な意味があると思っています。日本はこれまで国際法の尊重、人間の安全保障、人道支援の重要性を国際社会の中で繰り返し掲げてきました。だからこそ今日本に問われているのは、それを現実の紛争の中でどこまで一貫して守ろうとするのかという姿勢だと思います。それは特定の紛争当事者を支持するということではありません。むしろどの側であっても国際人道法違反は許されないという原則を守るということです。国際人道法は政治的に都合のいい時だけ適用されるものではありません。戦争という最悪の状況の中で、それでもなお最低限の人間性を守るために存在するものです。日本でこの問題を語るということは単に海外で起きている悲劇について議論することではありません。それは力ではなくルールが守られる国際秩序を私たちが望むのか、そして人間性をどう守っていくのかを問うことでもあると思います。医療を守られなかったとき、失われるのは一人の命だけではなく人間性そのものだからです。ありがとうございました。
はい、半沢さん、大変力強い、メッセージをありがとうございます。それではですね、ここで、皆様からの質問に、移ろうと思っているんですが、まだまだ、皆さんからの質問を受け付けてますので、もう少し、溜まってから、それを上げていきたいと思います。ですね、先ほど、今からもう一回英語に戻ります。So I'd like to switch from Japanese to English again. Maria, I remember I cut your presentation just before the last slide. Could you go back to your last slide that's calling for an end to impunity? What would be the messages from MSF to call for an end to impunity?
Thank you for coming back, but I think most of it has been actually answered. But just to remind again, I think what we said was that we have to move from rhetoric to actual action, that we do a protective frameworks do exist. The tools are there that has been mentioned by many. That the UN Security Council are just one part of the answer, but it's all member states' obligation to sign this to comply with IHL and to ensure the respect for it. And we also, of course, that would mean military practices are there entrenched with protecting healthcare. That investigation of violations are done and made public, and then therefore made to account. And that also means not only just annual reporting, but actually identifying those patterns, naming the perpetrators, and triggering an actual action from the council. I think it's also important to remind that for states that actually do provide support, intelligence, or whatever political backing, that should be conditioned on the respect for IHL. I think, again, as I said before, as everybody has said, these laws exist to maintain some kind of humanity and humaneness in an unfortunate reality of war. But unless that is preserved, there is values, there are rights and ethics are respected and principles are maintained, there will be constant inhumanity and impunity. And so we're trying to rebuild the immunity of humanity and try to be together in solidarity across the world. And that was the main message of that slide. Thank you.
Okay, thank you very much, Maria. Then we have a question from audience asking your opinion that Maria and Surama, Dr. Surama. What would be the message you would like policymakers or the media or audience in Japan to take away from this session? From which point of view, from MSF point of view, what would be your message to Japanese policymakers or the media or audience listening to this session?
I
Do
may
you want to go
start.
first? Go
Yeah.
ahead.
This is something I already conveyed a year ago when I met some of your representatives, and it was saying the voice of Japan is a strong one because of your history and the respect that you brought also, as I mentioned, in the concept of human security. You have contributed, to the global health and development agenda by showing also what does it mean in practice. So I was telling, use that, and the fact that, like in my region, in the MENA region, I said to JICA, you have a lot, and we were discussing this in the preparation of the session, a lot of investment in hospital and healthcare services have been supported by Japan. An attack on a hospital is also tax money from the Japanese that are lost beyond, of course, the impact on humans. So any community, any policymakers need to take, their responsibility vis-a-vis this. And you have platform, as I mentioned, that are multiple platform. You don't necessarily have a seat on or be able to influence the UN Security Council, but you have the Human Rights Council, you have, different member state-driven organization. This is where I think it's important. Being able also yourself to integrate, like some countries have done, I mentioned Spain, that having the humanitarian strategy, put the protection of medical mission as part of the strategy. It shows leadership. When a country says, I affirm that in my health or development strategy, the protection of humanitarian actors and medical mission is something that I stand for. It says it sends a signal to other countries. So there are multiple ways to show, I think, this. One is global advocacy in those circles in various platforms. We are negotiating at the moment a way to have maybe a human security, a human rights council resolution on protection of health. So there are various ways to implement funding. Support organizations that are also protecting, giving, provision of care in those circumstances. And JICA and the Japanese government have already supported. But also supporting, as I mentioned, the finance and the support of documentation of data system, because those systems, as I mentioned, documenting is a first form of resistance, but also a way that inform policy. We cannot have policy on attack on healthcare without being groups that are able to document it, and noting that documenting put at risk the people themselves often that are at the front line. Is not easy to do it. It's not just any research or any documentation in normal context. So there is also support for this system that allow you also to have that evidence, understanding the impact that is important for country to support.
And maybe to complement what Slim has said, I think for the community that's listening here, I think we all have a role to bear witness to that. And, first on just the rights of health and the rights for peace. Those are two equal rights that we should be respecting and be able to speak to that. As medical community, I think, for those who've taken the professional code of conduct, to remind what those medical ethics are based on, the proportionality, non-discrimination, and it's our voice needs to be on the table to remind on that, just the sanctity of medical action. And this is our call to all ministries of health, but all medical actors and providers. And then as I opened my intervention, I mentioned that I was at the high-level panel on the 10th anniversary a few weeks ago on May 12th. Of course, that was convened with Japan, and really looking forward to Japan's leadership on this and ensuring that there is compliance and respect for IHL. Thank you.
Great, thank you. Thank you very much. Okay, then Director Cristina, I remember that we passed the one of your last slides in your first presentation, the way forward for states and IHL duty bearers. Could you briefly go back to that your important points?
Yes, with pleasure. So the elements that I had not included in the presentation in the interest of time are firstly the observation that in total, I'm only aware of 2 cases where there have ever been any proper prosecution on incidents of healthcare, and they were related to the former Yugoslavia, as well as a case in the DRC. There are currently, to my knowledge, 2 open investigations related to Syria, something that happens under universal jurisdiction in Germany, and then there are domestic courts in Ukraine. But this is all that has been happening at the moment. So in terms of what is important for states to look at, I think it is twofold. It is, I think, as everyone has said, ensuring that the laws domestically and internationally are respected, but also implemented. And this is also for prosecutors in individual countries who can take measures to do this. But what states really have to do within the international fora is to ensure that they maintain a strong focus on the principles around IHL and the protection of healthcare, and not to let this slip away in the current context where everything seems to be open for renegotiation in some form. So I think, in short, what I would expect of states is to be strong on what is existing law and to see what can be done to actually enforce it domestically and through universal jurisdiction, and to support international courts to move on this, that there is support for the system that has been there and that I believe, while imperfect, has served us well for the last 80 years, but that I believe is at the moment at serious risk of being pulled down, at the risk of leaving us with very little to protect healthcare and civilians in conflict.
Okay, thank you very much, Director Christina. Then this will be the last question from audience I pick today. This is to Hanzawa-san. We got a question from Takenaka-san, Peace Winds Japan, specified non-profit organization. He or she said, I have a question for Ms. Hanzawa. Under international humanitarian law, there are detailed rules specifically mentioning how civilians must not be targeted. Among these, could you please explain, particularly from the perspective of the ICRC, the significance of the provisions related to medical care and medical personnel?
日本語がいいんですかね、英語がいいんでしょうか。日本語で大丈夫ですかね。
日本語ので大丈夫です。お願いします。
はい。文民の保護に関する国際人道法上の記載っていうのはもちろんその通りございますけれども、その中におけるその医療従事者あるいは医療施設等々への保護についてその重要性っていうことなんですけれども、やはりですね、どういうふうに説明をするのが一番いいのかなって今ちょっと考えてたんですけれども、基本的にその医療施設であったりとか医療従事者あるいは医療要員の人たちっていうのは文民の保護 っていうところにすごく文民の生命の保護、あるいは文民の健康の保護っていうところにすごく大きく関わってくる人たちだと思います。で、それに加えて、その戦闘員っていうところも考えてみると、やはりですね、その ICRC としては、その負傷した、あるいは病気の状態にある戦闘員の方々も保護される必要があるというふうに考えていますので、やはりですね、そういった国際人道法上、その攻撃の対象にはならない人たちと言ったらいいんですかね。越智先生、もし違っていたら直していただきたいんですけれども、そういった人たちの保護をするための、施設である病院、それからその文民の人たち、あるいは戦闘員を保護、戦っていない戦闘員、負傷している病気になっている戦闘員を保護するためのその病院施設、あるいは医療従事者という人たちは保護しなければならない。すなわち、その人の命を救うためにある人たち、あるいは施設っていうものを攻撃するっていうことは、やはりその人間性っていう観点から、やはりあってはならないことだと思うことからして、やはり非常に重要なことなのではないのかなと思っていますが、もっと法的な観点についてのご質問でしたら、越智先生の方がぜひもうちょっと詳細にお話ができるんじゃないのかと思うんですけれども、越智先生どうですかとか言って勝手に。
越智先生、どうでしょうか。
バトンを渡されたのでお答えできるところがあればと思うんですが、この保護のもちろん権限といいますのは、赤十字の国際委員会の創設者が、目撃した戦場での医療の、悲惨さということですけれども、なぜじゃあそれが必要なのかっていうことに関しては、国際人道法のコアとして戦争に関する正義に関するコアの、中核的なものとして戦争というのは敵の戦力を減らしていくことを目的にしている。人を殺すことを目的とするものではないということですね。なので戦闘力にならない、人の命を奪うというのは戦争の目的になるべきではないということですね。ですので、戦闘することができなくなった人や戦闘する意欲がなくなった人や、文民、そして戦うことがそもそもできない人たち、小さな赤ちゃん、やお年寄りの障害のある方なんですね。戦力にならない人たちを攻撃するというのは、基本どの法によっても許されていないことになります。で、その数を減らすために必要なのが医療ということですね。怪我をした兵士がまた、人間として、生きていけるようにするための、最後の、セーフガードですね。だからこの戦争の目的というのを、その戦闘力を減らす、そして人の命を奪わないと、この2つをバランスさせるために必要なのが医療だということだと思いますので、ここが守られなくなってしまった世界というのは、もう私たちは絶望とともに生きるしかないということになるので、最後、生命線だと半沢さんが強調されたのは、まさにそういうことかなというふうに思います。
はい、ありがとうございます。ではですね、もうお一人、これが本当に最後になりますけれども、島根大学の、坂根、さんからですね、質問が来ております。It seems many people around the world are losing their interest in upholding values such as IHL. How can we bring these values into the mainstream? It could be the last question of this important session. Maria Guevara, how would you think?
So I will combine my answer with also my last comments. Yes, thank you
Yes.
for putting that on the table. I think there were many already exchanges in the chat that I saw. It's about understanding what we're dealing with. So first, it's actually education and awareness of what these different situations mean. What are the laws? Understanding your rights and knowing where your values and your ethics lie. And that has to be there for us to understand what we each can play as far as our collective responsibility, and therefore what are the means and mechanisms we can then hold people who should be held to account. I think we need to understand that it starts with dialogue. In a globalized world and with the surge of technology, we talk to our phones, but we don't talk to each other. And I think it starts with human to human discussions. And what's really scary about the warfare today is that, you know, with the drones attack, you are far from the field, and you don't see actually the amount of lives you have just killed if you were pressing that button. So we need to bring back that human-to-human touch and contact. And then lastly, I think, you know, 2286 was a ray of hope for us when we came to the table in the UN Security Council in May 2016. Unfortunately, through the years, that ray of hope became a dimmed light of despair. But I think, as mentioned in the previous exchange, we can't abandon that hope. And for MSF, we will continue to hope and continue to fight and bring evidence to ensure that health facilities do not become the death sentences, but continue to be places to save lives. As a medical humanitarian worker, we are committed to this. Thank you.
Thank you, Gavara. Then same question and the last comment would like to have it from Director Christina. How can we bring these values such as IHL into the mainstream according to your opinion? Director Christina, yes.
Yeah, sorry. The Japanese at the moment was a little bit louder on this. So I think to briefly add to what Maria said and to the question in the chat, I think there are also key stakeholders who are perhaps listening today who I think can play a very important role. And I think these are academics, these are journalists, and most of all, I would also say the students, the next generations, to see what can be done to maintain and strengthen our systems. And to the question, what can we actually do to uphold IHL? I'm also very concerned with some of the significant changes we are seeing in the overall environment, and just to mention two, which is the way these principles are questioned on social media narratives, and the way technology around drones is also changing the situations of conflict. So I think what we need to do to uphold IHL in the future is to understand how the changing environment is putting healthcare at risk, and to adapt our responses under an IHL framework to a new environment. And that to me also means we have to be very strong at monitoring and assessing these changes, and to make sure that we contextualize them and bring them into conversations like these, that we actually get practical tools of where we can start to make real changes, to maintain the principles that we want, even in an environment that is actually fundamentally different than those of a few decades ago.
Great, thank you, Director Christina. Then the same question to you, Dr. Surama, and please share your last message with us.
No, same. I think it's really around first read, learn, understand what is at stake. In order to be strategic, I think we need to something. I learned a lot myself since we started 2 years ago. I was on the board of MSF 10 years ago when Kunduz happened, and I'm still learning every day. So I think the humility that we have to learn and read, because we are in a situation where social media people don't read anymore. We need to read and understand what is at stake to be able actually to defend. And then is to be strategic and build coalition. Whatever the level of you are, spend 10 years with WHO, sometimes as a clinician in Geneva with MSF, wherever you are, be a model as a medical doctor, or even in any, I mean, I have a professor of law with us here. Wherever you are, I think there is a way to contribute in your societies and globally. And that sense of solidarity, of a global solidarity among communities, countries, government is so important at the moment. When the multilateral world is collapsing to some extent, we need actually to reassure this, that the community, the people on the ground can make a difference. And I think I say to the students or whoever are here on this call, I think you have a contribution to make. I met a lot of young, very dynamic Japanese that were also taking a stake for this. I think we need to continue to do our parts and also bringing evidence, scientific and evidence data, and strategic stakeholder engagement. Thank you very much for the invitation.
Thank you very much, Dr. Surama. Then, same question and to you, Professor Ochi, and last message, could you share it with us?
はい、ありがとうございます。こういったセッションも大事ですけども、学生さんも多く聞かれてるかなと思いますので、日本は、この戦争の話題ですね、非常にタブーな時期が長かったこともあって、せっかく遺産がたくさんあるのに、まだまだ掘り起こされていない文章がたくさんあります。ぜひこの分野に興味を持った方は、多様な方法で学ぶ機会を見つけていただいて、私のゼミに来ていただいてもいいですし、最寄りの大学の方で見ていただいてもいいですし、またMSF さん、それからレッドクロスとか、さまざまなレクチャー、ウェビナーたくさんありますので、ぜひ学んでいってほしいなと思います。そして非常に関心を持たれた方は、専門家としてぜひフィールドに出ていくといいのかなというふうに思っていますので、これから私たちも、私もですね、含め、次の世代の育成というところも非常に重要、特に日本に関しては、そこについては、ぜひ頑張っていきたい。そして社会人の皆様もぜひ、お忙しいところかと思いますけれども、この分野しっかり勉強して、みんなで、この分野に、注目が当たり続けるように、頑張っていけたらと思います。今日はありがとうございました。
はい、越智先生、ありがとうございました。それではですね、最後に、私の方から、クロージングのリマークを示させていただいて、終わりにしたいと思います。本日、1時間半にわたるセッション、皆様本当にありがとうございました。本日の議論を通じてですね、いくつか重要な点が明らかになったと思います。まず言えるのは、問題は、規範が存在しないことではなくて、コミットメントとそれから現実の間に大きなギャップがあることです。国連安保理決議の2286という枠組みは存在しています。しかし、その枠組みが現場で十分に履行されているとは言えません。そしてもう一つ、非常に重要な点があると考えています。本当のリスクは医療の攻撃が続くこと、そのことだけではありません。それが当たり前のものとして受け入れられてしまうことにあるというふうに思います。決議はあると。しかし、履行されていないと。それは国際社会全体が医療を守るという責任を十分に果たしてこなかったからではないでしょうか。そしてそのしわ寄せを受けるのは本日 ICRC の半沢さんが言われていたように女性や子どもたちを含む医療を必要としている人々です。10年前ですね、日本はこの決議を実質的に主導した共同規約国ペンホルダーの一つでした。また日本はこれまで国連安保理の非常任理事国をたびたび務め、国際人道法の尊重を外交の柱の一つとしてきた国でもあります。だからこそ今問われているのは、日本社会がこの現実をどのように受け止めるのかということではないでしょうか。これを単なる共感の言葉で終わらせるのか、それとも外交や具体的な行動として支えていくのか。医療が守られない世界に私たちは慣れてしまっていいのかと、その問いが今私たち一人一人に突きつけられているのだというふうに思います。本日の議論がその問いを共有して考えるきっかけとなれば幸いです。本日はご参加いただき誠にありがとうございました。